So what I hope to do, I mean, you have a lot of misinformation out there. You're really being bombarded with a lot of information, much of which is good, but it's to distill that information and understand what may be speculative and what may more be driving panic and anxiety. I think one public health expert really summed it up to me the best. We have a pandemic of COVID-19, but also a pandemic of fear. And we need to distill, you know, what should be our reaction and what our tendencies are in terms of that reaction. So a lot of misinformation, a lot of anxiety. What is it not? I mean, Trinis are probably the best that I've ever seen in terms of coming up with memes, all right? Even though the Heineken is there hiding from the Corona, I still think Corona is probably the best tasting beer, all right? Calling in sick, and of course, I saw this one, which to me was the most interesting. To avoid coronavirus, spray 6 times per day, all right? I don't think that that may be a good idea. If I had to choose one, I would probably say punching is the best one to take to a trial, but I don't think any of them will work, quite frankly. So that's your icebreaker. Really and truly, you have a lot of myths out there, and I will try to address a few as we go along. What I want to do is just touch on a few key points, and of course, we look at questions that you may have towards the end. Now, I was told an hour, but we will try to compress it down into 30, 40 minutes and leave quite a few questions for the end. So what is it? Coronavirus, how it got its name. Listen, these things have been around forever, for a long time, and it pretty much gets its name because of that sort of appearance. That's what a coronavirus, this novel coronavirus, looks like a crown. So that's how it got the name coronavirus. It's really a large family of viruses, and I don't know if you guys will recall back to 2002, 2003 with SARS, and then more recently what we have seen with MERS in the Saudi Peninsula. Those belong to the same group of viruses. It's what you call zoonotic, a fancy term, but pretty much the natural reservoir is usually an animal, right? In this scenario, we look at bats. Whether a second animal was involved there, we will discuss later on. But you have a natural reservoir. There's obviously something that happened where there was a crossover from bats into humans, and of course now human-to-human transmission. Coronaviruses have been around for a long time, and they can cause mild illness from the common cold all the way to what we call severe illness, as in SARS, which has a mortality rate of about, you know, about 30% or so, 30 to 50%. Right? Common symptoms: fever, cough, shortness of breath, and breathing difficulties. So that's coronaviruses in general. If we look at how things unfolded, this thing started back in 2019, early December. And they identified a cluster of cases of pneumonia of unknown origin, and when they did their test, they were able to isolate a novel coronavirus, which we now call SARS-CoV-2. So the disease is COVID-19, but the actual virus is SARS-CoV-2. It all started in a wet food market in Hubei, and as I mentioned, the natural reservoir, you have bats, all right? That animal there that you're seeing is likely the second, we're not hearing.
Not here, but the stream not hearing, so we need it to use.
No problem, we'll do, that's fine, we'll do. Great. So you had a situation that animal there, it's an endangered, the pangolin. That could have been the intermediary part. You heard a lot about snakes and whatnot, but that is likely what they've traced it back to. The bats, natural reservoir, you have persons using that for the scales and whatnot, and it was in the live food market. It crossed from bats into that, and then from there into humans. So back in 2019, you know, there was animal to human transmission, but clearly what happened is the virus mutated, and you had a case of human to human transmission. I think where we've evolved to, obviously, is where you have sustained human to human transmission, but just understanding how those viruses work and where we've gotten to where we are today. So where are we at right now? Back in December, even into January, early February, China was the epicenter of this outbreak. However, things have evolved quite rapidly. Right now, if you look at about 2 weeks ago, there was a significant shift in that the number of new cases outside of China started to outnumber the number of new cases in China, with Italy, Iran, South Korea being the epicenter. And if we look at where we are now, I mean, you have probably about 135,000 cases, 5,000 deaths globally, and South Korea has started slowing down. China, you've had probably only about 45 new cases per day. And the new shift, obviously, we look at the US, they're up to 1,600 cases, but with the availability of testing kits now coming on stream, I think most public health experts expect that number to increase significantly. And by the time they would have reported their first case, there was likely about 6 weeks of human-to-human or community transmission that was missed. Italy, of course, is probably out there in terms of the cases, close to 12,000 cases or so, and you've seen all the massive shutdowns and public health measures that have been put in place. And of course, we're seeing the evolving situation in the Caribbean with our first couple imported cases. Then you're hearing Jamaica, St. Vincent, Guyana, and of course what happened yesterday. And I think it's important to note that that's our first imported case. So it doesn't necessarily mean there's human-to-human or community transmission, but we have our first reported case in country. You obviously would have seen that 6 cases additional confirmed in Jamaica. They're saying that 2 persons would have traveled through Trinidad, but of course there's Malaysia in there. They came from Malaysia. So I think the chief medical officer would obviously be chasing up with the Ministry of Health in Jamaica to better understand that travel, as well as what you would have seen with the chief medical officer in Alberta. So overall, the risk is, of course, very high. We know that a pandemic has been declared. What does that mean? You pretty much have a global outbreak of a novel virus. Generally, the population has never seen this virus, so there's no immunity. You have sustained community or human-to-human transmission in multiple World Health regions in the world. You have significant morbidity and mortality, and all the criteria would have been met for declaration of that pandemic. Another key question that comes up is, how is this transmitted? And I sneeze here, and it goes into the air conditioner, and it goes to the whole building, and everybody is exposed. That is not the case. It's not airborne transmission. Most coronaviruses, and this COVID-19, it's what you call a respiratory droplet infection. That picture sums it up. So someone is infected, they cough, they sneeze, you have these droplets are expelled. They don't usually travel very far, but if they land on someone, on their face, in their eyes, in their nose, into their mouth, you can become infected, right? That's the main mode of transmission, respiratory droplet, and someone coughing, sneezing in the vicinity of someone. Of course, if you cough or sneeze, if I have COVID-19 and I cough or sneeze and those droplets land on this desk, there is a smaller potential that those particles are here. You come a little bit afterwards, you touch that desk, and you don't wash your hands, you don't use hand sanitizer, you touch your face, your nose, you adjust something on your eye, you can get it to a lesser degree like that. But the main mode of transmission is via respiratory droplet, all right? There's something called an R0, which you will hear a lot about. That essentially measures the transmissibility, or how easily something can spread. And all provisional reports with this novel coronavirus is that that's about 2.0 to 3.0. So for every 1 case of COVID-19, that person will likely spread it to 2 or 3 persons in the community. All right? So it is fairly transmissible, but it's not the worst of the lot. I'll show you a graph to put it into perspective. All right? I mentioned poor survivability on surfaces. I'll explore that in another slide. But by far and large, these coronaviruses do not fare well outside of the body. Outside of the body, it's quite harsh conditions, so they're thinking minutes to hours, whilst you're seeing some people coming out and saying potentially days. The risk is actually quite low, and these viruses die fairly quickly outside of the body. All right? Incubation period. So what is this about? From the time someone is exposed to someone with COVID-19, and let's say they are infected, so their body is harboring this virus. They are incubating that virus. So from the time you are potentially infected to the time you manifest symptoms, that's what we call the incubation period. So that range can be from 2 to 14 days. 14 days is the upper limit, although they're showing that probably it could be longer than that, but in a small percentage of persons. Most persons will become ill within 5 to 6 days of exposure. So that's the sort of time frame you look at. There's a lot of information around persons without symptoms spreading COVID-19. We need to put this into perspective. The data is clear from Johns Hopkins, World Health CDC. 97.7% of persons will spread this disease only when they are symptomatic. So that's the bulk of the transmission. If there is some spread with persons who are asymptomatic, it's going to be the minority of cases, not the majority. All right, that's the data, what the data is showing so far. Symptoms, I mean, the main symptoms would be fever, a dry cough, sore throat, and of course you go on to shortness of breath and whatnot in a small percentage of cases. The small percentage of cases that go on develop pneumonia and breathing difficulties, but those are the 3 cardinal signs to look out for: fever, sore throat, and breathing difficulties. Of course, you have the other flu-type symptoms that you can develop: muscle pains, you feel lethargic, and the small minority of cases that develop complications become septic, kidneys fail, and whatnot, so it goes through the whole spectrum in there. In terms of severity, and I think this is a very important message, distilling the information and understanding, putting things into perspective. The majority of persons have nothing to fear with this virus, all right? It's 80% of persons will actually just have very mild symptoms, and some persons may have no symptoms at all. You may not even know that you have it, which is good at an individual level. It's not necessarily good at a population level because people feel not so ill. You know, I could go to work, I could go to the supermarket or whatnot because I'm not feeling too bad. But because of that, the spread is the picture that you're seeing now. All right? Of course, 15 to 20% of persons will go on to more severe illness. And usually this group, what we're seeing, equates with the elderly. And I mean, I don't want to insult anybody here because I didn't think 60 and above is the elderly, right? But 60 and above seems to be a particular at-risk group, and 80 and above an even more significant at-risk group. Of course, your diabetes, your hypertension, your cardiovascular disease, your pre-existing lung conditions, those also appear to be affected more severely, and I'll show you a slide to reflect that. About 5% of all cases will require ICU support, oxygen, ventilator support, and whatnot. And this, I think, is what you're seeing, for instance, in Italy and what you saw in China, where the capability of the healthcare system to support that. Because if you have, you know, let's say 100 people requiring ventilatory support and you only have 50 ventilators in country, it becomes a problem. So that's where the public health issues start creeping in, and the capability to cope with disease burden becomes an issue. Mortality rate, you see, World Health would have put out 3.4%, but that may actually be a bit artifactually increased and high because what we don't know is the true denominator, the true number of the total number of cases. So that will likely come down as things progress. All right, I think most experts agree it will probably be between 1.5 to 2.5% or thereabouts, which doesn't sound too high, but if you compare seasonal influenza has a mortality rate and it kills, you know, 70, 80,000 people a year in the States, that has a mortality rate of 0.1%. So even if we settle at a 1% mortality rate, that is still 10 times more deadly than influenza. So we have to put it into perspective, but also understand that it still carries significant implications. Of course, there's no treatment, right? It's really supportive, and there's no vaccine. Vaccines probably won't be available for at least a year. there are a couple of drugs that are showing some promise, and I think it's probably the best option at the minute in terms of what will be available in the short term. I just want to emphasize here the outcomes, and I really just stole this completely from Facebook. This was excellent information here, which really summed it up nicely. You can see on the left, mortality rates based on age, and I think what I want to show, is there a pointer on this by chance?
Yes. Yes.
The top?
Center.
Center, right. Good. Perfect. So by age, you look at by age, as I mentioned to you, the over 60 group mortality rates go up significantly, and the over 80 group, it can get almost up to 15%. So the elderly are really severely affected by this virus. As you can see, from 60 and under, the mortality rates are actually quite low in comparison to the others. And one area I want to address is around children. 0 to 9, no deaths and very few cases. 10 to 19, 0.2%, which is still quite low. And for some reason, which I don't think we fully understand, children are not really adversely affected by this virus. There are theories around the fact that their immune system isn't mature. And what really causes the lung issues is an inflammatory immune reaction where you have lung damage and then you progress to severe respiratory distress and failure and whatnot. So because of that, kids, we don't really have to be overly concerned from a disease perspective. But why? You're probably thinking, well, why doc talking nonsense here? Because they're shutting down schools. And that is a good point. But at the end of the day, they may still play a role in transmission. So they may be asymptomatic, going about playing normal, but they're spreading it to the elderly and the parents at home, etc. Right? But kids are fairly protected. Note that the elderly, very severely impacted. And if we look at pre-existing conditions, what I mentioned, cardiovascular disease, diabetes, etc., you can see where the mortality rates go up significantly in there. For persons with no existing conditions, mortality rate is actually quite low. So take-home message here, the elderly, over 60 and over 80 age groups, and again, I think it's not fair to say over 60 elderly, right? But that's the information being presented, and persons with pre-existing conditions, really the at-risk groups. Or why we don't use Tamiflu, which we use to fight influenza, it doesn't work, right? So no treatment, no vaccine. We mentioned the supportive care ventilator support that is required for 5%. And the one drug that is really promising is remdesivir, which was actually introduced for Ebola, and it's showing very positive effects thus far, right? Some others, including antimalarials and whatnot, but we're more likely to have a positive impact with this pandemic from those drugs rather than a vaccine. Some have gone into trials and whatnot, but you're looking at least a year, realistically, before that is available. This slide really just to compare, because you know, I think putting it into perspective is important. You look at the percentage mortality on this axis and how easily it's spread. Remember we spoke about that R0. COVID is somewhere around here, and if you compare to other things, measles, which is airborne, remember COVID is not airborne, so this is highly contagious, and then you have your bird flu, which has high mortality. So you kind of see where we are here, and this is where seasonal influenza lies. So it's somewhere in the middle. I think significant impact at the population level, at the individual level, unless you fall into those at-risk groups, really and truly likely to have more mild disease than anything else. So what's the current situation? I told you it was rapidly evolving. I mean, we go back to January, a public health emergency, international concern declared. You obviously now have a situation that is a pandemic. We haven't had a pandemic scenario since 2009 with H1N1, which we all know as swine flu. You obviously have significant responses, you know, airlines not flying, a lot of travel restrictions, lockdown of large areas, cancellation of big events, you know, football leagues, cricket leagues, basketball, baseball, you name it. Olympics, they're going to make a decision, I think, by the end of May. And a lot of people, you know, schools closing, you're looking at a total lockdown in Italy. And the philosophy is that the countries that implemented these sort of lockdowns early on, you know, may have impacted the spread. You know, you look at the Singapore and the Japan in particular. So it's just looking at where we are at the moment. From a Trinidad perspective, of course, you had travel restrictions implemented, which covered China, Japan, South Korea, Iran, Italy, Singapore in the beginning. And obviously, based on the evolving scenario in Europe, France, Spain, and Germany would have been added on. As I mentioned to you, the new epicenter, Europe, the UK, and the US, where you have anticipated an increase in cases. It's probably highly unlikely, even though public health would tell us that those are potentially the areas with the greatest risk. We have to factor in geopolitical issues and whatnot before any travel restrictions are declared at a national level. And I think obviously from a company perspective, you have to give that deep consideration before making any sort of decision around that. You do have increased screening at most ports in keeping with World Health, you know, temperature screenings, thermal scannings, they will ask you questions, etc. And we do have a national response plan, which, you know, I usually talk to the Chief Medical Officer sometimes at least 3 times a week, sometimes daily, because things are changing so rapidly. Just for your information, Cora would have been fully operationalized, where you have 24 beds now available. And Couva, the new facility at Couva, should be operationalized from what the Chief Medical Officer said, likely from today. Right? So those would be the key 2 focal points, but of course using your health centers as your focal points for calling in if you think you've been exposed or you're returning from an area with COVID-19 outbreak. So we could probably talk about that because I'm sure we'll get some questions from within the room. Testing capabilities there, but all testing has to be run through the Caribbean Public Health Agency, CARPHA, usually a turnaround time of 24 hours, could be up to 48 hours, dependent. And you will hear about some labs, right? 2 labs in particular in country that can, they claim, do this type of testing, but it's just to understand that that won't be a confirmatory test if it comes back positive or negative. The only body that is recognized with regards to testing is CARPHA. What do? Doesn't involve, it's not too invasive, it's usually a nasopharyngeal swab. They may actually, they put a swab up into your nostril, sometimes they can swab the throat, and if you have a very productive cough, they will take a sample of that and send it to the lab for testing as well. All right, so what can you do to protect yourself? Social distancing, right? We need to start thinking about these things where, you know, you avoid large gatherings, you maintain safe distance from persons, especially if someone is ill with a respiratory type illness. You want to give them wide berth, not because they're smelling bad or anything, but you're protecting yourself, right? Hand hygiene, I can't stress this. This is probably the most powerful weapon in the arsenal against COVID-19. Washing your hands and using alcohol-based hand sanitizer, right? That is so important because of the fact that you can touch a contaminated surface or whatnot, and then you touch your face. Washing hands, very, very important. If possible, you avoid touching your face, eyes, mouth, nose, right? If we observe ourselves in a minute, you'll be surprised to see how many times, and I've probably done it as well, subconsciously. Just retraining yourself. Don't touch your face, don't touch your eyes. At least make sure you've washed your hands before doing that. Very important to have flu etiquette. So if you are ill, now to start with, you shouldn't be out to work or anywhere else in a public space. But if you are ill, you cough or sneeze. Remember we talk about respiratory droplets. You cough or sneeze into crook of your elbow, or you use some tissue, you sneeze into that, and you discard off and wash your hands, right? You don't just achoo and you spread it all over the place, right? So you cover those. If you are ill, stay at home. The current scenario, you have 1 imported case. There's no evidence thus far of community transmission or spread from one person to the other in country. But when that does happen, you're not going to be able to distinguish. Someone comes in with a cough, a fever, a runny nose. You don't know if it's common cold. You don't know if it's influenza. You don't know if it's COVID-19. So that is a critical barrier in protecting persons in the workplace as well as your own personal responsibility to others at home, right? So stay at ill if you're home. We mentioned the 3 feet, right? Usually to be a close contact, you have to come within 2 meters of a confirmed case and spend at least 15 minutes. That's the public health guidance in terms of what is a close contact, right? But give everybody wide berth, right? I think Himmers and his team, they would have already looked at internal, because cleaning of frequently handled surfaces, door handles, doorknobs, you know, restroom areas, work areas, keyboards, those type of things, critical within the workplace to maintain that sanitation quite frequently. Get the flu shot. Will the flu shot protect you from COVID-19? What do you all think? It won't. But what it does is it's less likely if you become ill that the physician who's attending to you will say, listen, it's less likely to be influenza because of the fact that you've had a flu shot. So the guidance from the CDC and World Health is it makes sense. And in any case, it is circulating now. We're in flu season, so you protect yourself from that. All right? Don't travel if you're sick. Obviously, if you're sick, you can spread it, but they will likely flag you, and you could be subject to quarantine, so you have to be very careful now. In fact, defer all non-essential travel. That's a good guide from the Ministry of Health. If you don't have to go, don't go. And of course, seek medical attention early. We will run through. If you guys have questions around what you should do if you think, you know, you've been exposed or you're returning from a high-risk area, we can always run through that if you have any questions. So why is this so important? And this is a huge personal responsibility, your responsibility to yourself, your family, your co-workers, and quite frankly, to the greater good of mankind in Trinidad and Tobago. What we saw on the previous thing in terms of prevention measures, there's something called flattening the curve, which Himmers and I were talking about earlier. This is how a pandemic wave usually goes, right? You have a steep rise in cases because remember you introduced a new virus into a population that they've never seen this before. You have a steep rise and, you know, institutions struggling, they can't cope, the doctors are overwhelmed, you have no beds, and then of course it comes down, right? This wave usually could last up to 12 weeks, sometimes longer than that. But if you have all those public health interventions from the social distancing, your hand washing, and, you know, if the government opts to, depending on how the circumstances go, you know, cancelling schools, etc., what this does is it flattens the response and the number of cases so that your institutions don't have to deal with this. Your case count is overall lower, but also the peak number of cases is also lower. So it gives your healthcare system a chance to cope with the load, right? So this is what you have some control and input over. We probably hear a lot about, that's the concept essentially. So I know some questions would have come up. Face masks, right? You're going to just wear a surgical mask and you're going to protect yourself and whatnot. You see what happened in China. So there are two options here. Surgical masks, we'll deal with that first, right? You all know what a surgical mask is, right? The one that is fairly flexible and you tie around and whatnot. That is, this guy here is wearing a surgical mask. That provides little or no protection from COVID-19, right? The rule of surgical masks would be if you have a suspected case, you put a surgical mask on that person, so when they cough, they sneeze, they're not broadcasting it and spreading respiratory droplets. So wearing that, going out to the grocery and whatnot, is probably a total waste of time. The one that has been shown to potentially be of value is the N95, which is a respirator. That's the one that has a snug fit and it fits fairly flush on the face. That adds value, but it should be restricted to use by healthcare professionals, first responders, etc. There's clear evidence there, persons who know how to use it. If you decide you're going to walk around with an N95, the World Health, CDC, Johns Hopkins, etc., you're pretty much putting yourself at an increased risk. Because one, the most and the best thing you can do to protect yourself is wash your hands and stay away from sick people. If you're not accustomed wearing an N95, it's hot and it's uncomfortable. And what you're going to be doing is, oh boy, this thing hot, you know, and adjusting, fixing, and this and that. remember what the mask is supposed to do. It filters the virus. So you're concentrating likely those particles and other things on that mask. So there are clear protocols that you should be undertaking. Every time you touch that mask, you should be washing your hands. So in the general public, it is not advised, and N95 will actually likely put you at an increased risk of contracting a viral disease, right? So little value, but it's just putting it into perspective because you're seeing a lot of people and, you know, rush to buy N95s, face masks and whatnot. If you guys have any questions around that, I will field afterwards. Packages. So everybody, when you zone pull up and they offload your package, you put on your mask, you put on your gloves, you're spraying it on with Lysol because it come from China, right? Well, guess what? The risk is pretty much almost zero, right? From that type of transmissibility is very low. And the fact that those goods have taken weeks to come, it's highly unlikely that a coronavirus can survive in that harsh environment. They love to be inside of you. They don't like to be outside, right? So very low to almost zero there. Of course, the burden of disease has shifted from China, so we'll need to adjust that. Home remedies, garlic, don't work. I heard in the UK, Schweppes tonic water, you can't find it on shelves. They don't work. I am not a good bush doctor, but that's supposed to be chandelier bush. It don't work, right? People say using chlorine, cleansing yourself with chlorine, bleach, and alcohol don't work, right? You guys will probably have some better than me. I mean, and I think one person said when Trevor Sears doesn't come up with a cure, we're really in trouble, you know, but you have to mind the human. If you have any questions around any specific ones, antibiotics don't work, antivirals don't work. I mean, we've gone through this, but be mindful of what you read and what people claim, right? I know I'm mindful about the time, so I'm not going to spend too much time on this, but look after your mental health and psychological well-being. This is a very uncertain period. You're being bombarded with information. There's a lot of anxiety. People talking COVID-19. You're looking at gas price. You're looking at oil price. Stocks crashing. You know, people worried about their job. So look after your mental health. To me, focus on what you have direct control over. You cannot control oil and gas prices despite what you might think. You can't control how the pandemic is going to evolve. Focus on what you have control over. Look after yourself. Get enough sleep. Exercise 4 to 5 times per week. Look at what you're eating. Remember, when we're stressed, you tend to have unhealthy coping strategies. So you feel for the KFC, you feel for the chocolate, you might drink more, you might smoke more. So be mindful of that. And at the end of the day, a lot of us, we do safety critical jobs out there, or you operate a vehicle. And this is a time we have to be very careful and mindful of distractions. So look after yourself in that regard. So to sum up, no need to panic, but absolutely you need to be prepared. All right? There's still much we don't know about the virus, but the key message is that most persons will have a mild infection. We need to look after the groups and protect the groups that may be prone to more severe illness, your elderly, over 60, over 80 groups, and of course your persons with pre-existing conditions.
Thank you, Doctor. So we'll take some questions from Slido, or if there are questions in the audience. Morning, Dr. Thanks for your presentation.
Sure.
You mentioned productive cough. What is a productive cough?
All right. We usually use fancy terminology to look bright because we're not bright, right? But a productive cough, when you can have either a dry cough, which you're not bringing up anything, or a productive cough, you bring up some phlegm or mucus, which could be clear to colored and fancy colors as well. So productive is you're bringing up something.
First question coming from Slido. How does staying at home, if you have flu-like symptoms, affect your sick leave balance? And that's a question for HR.
We need to ensure that we speak to our supervisor about that first, of course, right? So if we have flu-like symptoms, yes, the guidelines from our company doctor and World Health Organization is that you stay at home. If you can work from home, then those arrangements should be put in place in conjunction with your supervisor. Supervisors, you have responsibility to ensure that the employee can in fact work from home and that you have some sort of check-in mechanism. In that instance, you'll be working from home and you'll be working. So that is not going to affect any of your leave balances. If you're an employee who cannot work from home and you're just sick, because we had another question, I just want to kill two birds with one stone. Sorry, we had a question from Albert. Albert here?
No.
Albert said the common cold may mimic the signs and symptoms of COVID, and an individual may stay at home, but then proven it is not the subject virus. How does this impact NGC sick leave benefits? Right, so similar. So if you stay at home because you have flu-like symptoms and you cannot work from home, so it means you're not working, right? And you have not been one of those persons who are subject to quarantine. So the doctor talked about quarantine, right? Then that sick leave will impact your regular sick leave entitlement. So the normal rules will apply. In all cases of if you have to stay at home, we are asking that employees, if you have to return, you're not fit to return work before you come out to work.
That's what I'm clear about quarantine. Is it not you have to be quarantined somewhere, or it is self-quarantine at home?
Okay, so based on World Health Organization guidelines and guidelines from our doctor, if you are in one of the categories for quarantine, meaning you travel to a country where there are confirmed cases of COVID, then the recommendation is you self-quarantine for a period of 14 days. That quarantine will be at home.
So I think you have quarantine and then you have home isolation, right? So let's say you come back in from Italy right now. You come in, you're a resident, because if you're not a resident, they will book you straight back on the next flight, not first class to go back wherever, right? If you come in, you will be screened by Port Health. If you are asymptomatic, you have no fevers, whatnot, they pick up nothing, they will allow you home in self-isolation. And so pretty much everybody leaves the house, or if they're there, you isolate in a room. Ideally, you're supposed to have national security outside to make sure you don't leave. And the district health visitor or the county medical officer of health for that district or county would go home on a day-to-day basis to check temperatures and whatnot. If you have, like, let's say the gentleman yesterday, the first imported case that was confirmed by CAFA, so he had a positive travel history, he's developed symptoms, they did a test, they advised him isolation at home for 14 days. The test came back positive, he's symptomatic, he was moved off to Cora. All right, so that would be the protocols. Once you're symptomatic and a confirmed test for now, you will be moved to Cora plus or minus Cuba if it's operationalized. So if you have a confirmed case, that would be the protocols. Correct. Well, once you confirmed, if you fall into another category, which is a close contact, so let's say the CAL flight people who were potentially exposed to the Guyana case, they would put you at home in quarantine, self-isolation, with Ministry of Health doing daily checks for you. But from the time you become symptomatic, at least for now, you will be moved off to Cora plus or minus Cuba. Right? As things progress, that can change because you have to look at your capability and your bed space and whatnot. It may very well change at some point, looking at the UK and whatnot, where they allow mild cases to stay at home, and if it gets worse, you come into hospital and whatnot, right? So that would be the general operating plan and philosophy for the ministry, right? If you think, I think we had a good question, if you think you have potentially been exposed to someone with COVID, or you came in from one of those countries, the US, Europe, or something that is not on the restrictions, then the advice from the ministry is, one, don't go to the health center if you're not, you know, I mean, if you are struggling to breathe and whatnot, you report immediately to nearest emergency. But this is if you're stable, but you develop a cough, a little shortness of breath, well, not shortness of breath, fever or whatnot, you call the nearest health center, and they will make arrangements to have someone come to you to carry out a test if required, or direct you to go to an institution to have a confirmatory test done, right? That would be the protocols. But the key thing is, don't just show up, and definitely don't go to a private institution or a GP, because they will not see you. All the big institutions right now, they're not seeing any cough or cold, private institutions, because it's treated as COVID-19 until proven otherwise. All right? All right. So we have a couple of questions here. If you have contacted COVID-19, how long it will take to go away? Usually we look at about 7 days, right? Public Health England just put out some advice, 7 days. I mean, initially we were thinking 14, but usually in 4 to 5 days after symptoms start, you would feel better if you don't develop complications, right? But 7 days is the sort of rule of thumb there. Do pregnant women fall into the high-risk or at-risk group? That's a very good question, because with influenza, pregnant women, because they are somewhat immunocompromised, because you don't want the body rejecting the fetus, so the immune system runs a little bit under par. So with influenza, they are at risk. With COVID-19, I don't think there's any data thus far to support that. So I would say we probably don't fully know or understand that as yet, but the data doesn't suggest that they are at a high-risk group. Should the response to COVID-19 threat be any different from the response to any other flu? So that is a trick question, a good one. So if you were dealing with a pandemic scenario of flu, for instance, H1N1, the key principles are the same, but we also need to factor in the fact that, one, this is probably a little bit more transmissible than influenza. And remember, we looked at the mortality statistics. So mortality with influenza is 0.1%, whereas mortality with this is probably at a minimum 1% all the way up to 3.4. So it is at least 10 to 20 times more deadly. So I think the public health authorities have to react based on the level of threat. And this is not just a normal flu. The principles would probably be the same if you were responding to a pandemic flu scenario. Right? But it would be more drastic from what you're seeing with lockdowns, isolations, widespread quarantines, etc. And remember, with influenza, you have antivirals to treat it, Tamiflu. You have vaccines that you can develop very rapidly. Coronavirus has no treatment, no antiviral is working, and you have no vaccine. So it's different.
Right. The NGC Group provided flu vaccines to staff, and it was extremely unsubscribed. Why don't we like to get the flu vaccine?
Yep. Just by a show of hands, if by tomorrow there, I mean, this is not going to happen, but if there was a coronavirus vaccine, how many people would be willing to take it? Tried and tested, exactly. So trainees are generally like that. They wait for things to get hot, you know, then to rush in. So
Doctor, can I add? I took the flu vaccine and I got extremely sick.
Yep.
I know everybody reacts differently.
Yep.
So it's for that period that you are recovering, are you opening up yourself to be exposed?
Yeah. So that's a good question, and it's a very common one that patients ask me and employees would ask. So this is a dead, inactive vaccine. So technically, a flu vaccine cannot get you ill. You have potential side effects and whatnot, but you can't get the flu from the flu vaccine. The other thing is, a flu vaccine would usually cover you from 3 or 4 specific strains of influenza, H1N1, H3N2, Brisbane thing, and this and that, right? So it doesn't cover you from all, And remember, you have other coronaviruses that causing the common cold, RSV viruses floating around causing the common cold. So it may be that the timing may not have been good, that you had the flu vaccine, you probably were incubating something else, and you became ill. So, but it is a common question that is asked. But it's a dead vaccine, you really should not be ill. Most you might get is a little bit of pain at the injection site, and you can get a mild fever, not because you got the flu, but because your immune system is mounting the antibody response that it should be doing. Italy has basically closed its borders. Is this an overreaction? I don't think I'm the right person to answer that, but I think based on what you have seen, where Europe, the US, China, you've seen this explosive spread, and you compare to countries like Singapore and Japan that implemented massive shutdowns, massive quarantines, significant public health measures where they make sure they contact trace every single case. With those, the others you've seen steep spikes, and these have leveled off early on. But the thing is, I mean, you have these lockdowns now in Italy, but the question is, did they miss that golden window of opportunity before implementing it? Right? That to me is a big question. I don't think there's any right or wrong answer there. Can you get a relapse of disease if you recover from it? So that's an excellent question. There's a lot we still don't fully understand with COVID-19, but I think generally there's consensus that if you have COVID-19, you recover, you will have some degree of immunity to COVID-19, but how long that will last, we don't know. If it behaves similar to other coronaviruses or influenza, you may have some immunity that peaks and then starts dropping over the period of a year. But if we were to say 6 months, a year, 2 years, I think would be being speculative. We just don't know. Right? Today's Guardian, page 35, Minister of Health says to visit your closest health center or doctor if you suspect infection. This is dangerous advice, no? That's a leading question with an answer. But so it's not to visit your local health center, it's to call, because, and this is not something specific to Trinidad. In fact, Southwest has a hotline that you can call for advice in terms of how to proceed. You will probably see similar being rolled out. But I think the key thing about calling ahead is you trying to minimize potential exposure to other persons as well as unnecessary burden on the system and exposure to healthcare workers. So for instance, in the US and the UK, you have drive-by testing, you know, and these similar type of hotlines that are set up where you call in if you have a positive history and you have symptoms, positive travel history or positive exposure. They may then, they will come home to you to do the test and then operationalize the national plan from going into Cora or Couva. So the key message is don't go to a GP, don't go to a private institution, don't show up unannounced at a health center. Call ahead, use the numbers that have been provided, and of course the caveat in there, if you are having a massive asthma type attack and shortness of breath, difficulty breathing, you're not going to call and wait. You go straight to the nearest accident and emergency. Should persons who recently traveled to European regions affected by COVID-19 in the past week self-isolate even though they show no symptoms? I think, there's no right or wrong answer there. Some countries have adopted that approach, and I know certain companies may even be considering that. So as of now, from a Trinidad perspective, I don't think it would be a position that you self-isolate. That would be a decision made when you come in, Port Health screens you, they would advise you if, based on your travel history, your contact history, if you should, and if they will operationalize that aspect where they have a Ministry of Health official coming home to you to do temperature checks, etc. I won't give my personal opinion on that because I don't think it would be responsible to give that up. Maybe afterwards you could ask me. What is the update on the use of malaria, chloroquine, phosphate, and zinc to treat pneumonia brought on? This is an excellent question. So that is one of the drugs. Chloroquine, which is used to treat malaria, has showed some positive potential, right? And this is something that is readily available. I don't think the studies are completed where it will be used as a first line. Right now they're trying multiple experimental drugs. The one that really shows promise is that Ebola drug I mentioned earlier on. Zinc, I don't think there's any body of evidence, but there's no harm in taking vitamin C, 1,000 milligrams twice a day. It's water soluble. You pretty much pass out any excess, right? And zinc is always a good antioxidant. But I can't say that there's evidence to show that that will stop you from getting COVID-19. All right.
The other question is directed to HR. If a family member has COVID, what type of leave would apply, if any?
Thanks, Althea. So if a family member has COVID, most likely the recommendation from the health professionals would be for self-isolation of that person and their family, or depending on how bad it is, I guess, quarantine, according to the doctor. In that case, we have on success factors an option to select something called compensation. No, not compassion. Compensatory, right? So what we are recommending, and disclaimer, we are preparing for the President's approval, and it's being reviewed right now, work from home policy to treat with all these types of questions. But in the meantime, you can select that option on success factors, and please upload the verification documents for there. And that type of leave is paid leave. So that's not out of any of your entitlements. But we must keep track of that type of absence because we can't track it any other way. So you must go into success factors and put the appropriate comment. And once it's verified by HR and approved by the line, it will be paid leave. Employee station and TGRF have begun to raise concerns about what are the NGC's plans toward employees who are resident in Trinidad and frequently travel between Trinidad and Tobago to report for duties. All employee stations at TGRF frequently interact with external departments within the NGC who send personnel to TGRF to perform duties. Looking on from what has been happening in the outside world, a lot of transmission comes from people traveling one country to country using either air or seaports. Can you tell us what measures will be put in place to deal with these concerns? So, as the doctor mentioned earlier, it is international travel that we're dealing with. Domestic travel, so far, it will be a regular guidelines that the doctor provided in the slide this morning.
These non-process facilities, we've also taken a decision to limit the persons who are allowed to go to those facilities. So that's part of the control rooms and that sort of thing. We consider to be critical infrastructure, and part of the planning for this would look at a restriction in the type of activities that we are allowed to continue as we progress through escalation. And those type of activities would be limited, and therefore the persons who should be going to those facilities would be limited. Basically to those critical operations and maintenance type activities. So we will continue to change shift and change crews. As we escalate, we may need to consider changing work arrangements. And we're looking into that right now, working with operations and with HR. To potentially move into a different work structure where we may change shift left frequently and build that out as we go. So I think it's a really good question. We've started to think about it. We've already put the restriction in place with respect to visitors like myself. Frederick, so I wouldn't be coming to Beachfield or Tobago because I'm not critical, right? To really the guys who really need to be there, because we really do need to preserve what those facilities look like in terms of visitors, and just keep it to critical people.
Do you know if contact tracing is happening on the flight JFK-TT guide, which had the Guyanese COVID case?
Yeah, that's a good question. Obviously, there are a couple challenges with that case, because obviously that one would have been diagnosed post-mortem or after death. So you would have had a bit of a delay from the time it is confirmed as COVID to when you're able to institute your contact tracing and whatnot. But yes, they have. The ministry has sequestered the CAL staff who would have come into contact with that individual. And from a public health perspective, they usually look at 2 seats in front as well as 2 seats behind the suspect case as a potential area for spread. And that has been done from all information from the ministry and the chief medical officer. Similar has been done for the suspect cases, well, the confirmed imported case in Trinidad.
Is the company, physician, or NGC giving any thought to periodic checks or screening of staff?
Yeah, I think the screening that we're doing with respect to staff from a medical standpoint is based on presenting with symptoms, right? What we are doing is we're looking at, and we did this as part of the step change from no cases in Trinidad to 1 cases. We're in the process of procuring some thermal scanners where we'll be able to do similar type of temperature scans that they do at airports, again, for the critical facilities. Again, I'm making a statement publicly that if people are ill and have fever and they take a fever suppressant drug, there's a potential that the fever might reduce and they could come through. So people really need to check themselves, and if you're ill, you need to be respectful. I like the term doc use, right? Flu etiquette. You need to practice flu etiquette with respect to that. But if there's any additional, personal things, I think we would refer people to the protocol that the Ministry of Health have provided.
And if I could just add, I mean, a lot of people coming with questions, well, I can't have a COVID-19 test, every so often to make sure, But we have to understand, this is a pandemic. You have testing kits are going to be limited, and you're really going to need that for sick people to confirm and treat accordingly. So it should not be, it'll be a waste of resources to be doing testing on well asymptomatic persons who have no contact and just want to know, well, I'll come back from the States, I want to do a COVID test, It's less than ideal.
Another question, is NGC management considering telecommuting where possible?
So the short answer is yes. We have a policy in draft. However, we have the risk management team have different response stages. We are not at that stage yet, but we have a policy in draft, and if we get to that stage, we'll have an approved a policy that's approved by the president for that. So the short answer is yes.
Thank you to our panel, and I think we are at the end of our session.